Good morning, everyone. Welcome to TeleShadowing. We are recording this session and live streaming it to YouTube. We will be having a Q&A session at the end, and you can ask questions in the YouTube Live and Zoom chats, and they'll be addressed. I'm honored to introduce our mentor for today, Dr. Manal Ahson. Dr. Ahson is an American of Pakistani descent who has made many medical mission trips around the world. She is an assistant professor of internal medicine and pediatrics at the University of South Florida. She's also the chairperson of Med Global's Volunteers and Networks Committee and has provided medical relief work in 7 countries. I would now like to request Dr. Ahson to start today's session. Thank you.
Good morning, everyone. Thank you so much for having me. Thank you to Dr. Chima and the entire team for asking me to come today and give you a little bit of insight about I guess what I do, and give you my topic today is an update on COVID-19. So I know many of you are preclinical, so maybe you don't have a lot of clinical experience, but have been hearing a lot about this in the news and the media. So hopefully I can give you a little bit of a clinical background on what some of the treatments are right now, what has changed, and kind of in what direction we're going. So please feel free to ask questions in the chat, and I know they will compile them and we'll ask them at the end. Feel free to ask any questions about my background, how I got to this career path, all of that stuff as well. But I will give you a little bit of give you some updates on that too, or give you some background about me. I'm sorry if I sound a little discombobulated. I actually just finished the night shift. So I worked last night. As you know, Florida is going through a COVID-19 surge right now. So we've all been working a little bit extra. So usually this is when I come home and go to sleep. So but I'm glad that I was able to kind of fit it in with my schedule. So I will be sleeping as soon as this is over. So if I'm a little bit, if I stumble over my words a little bit, please forgive me. So let me go ahead and share my screen. Okay. Okay. Can you see that?
Yes.
Okay, great. Okay, so as was mentioned, my name is Dr. Manal Ahson. I will give you a little bit of background about me, but hello from Tampa Bay, Florida. Any of you that follow sports know that we did really well in sports last year between our Tampa Bay Buccaneers, our Stanley Cup winning, back-to-back Stanley Cup winning Tampa Bay Lightning, and as well as our Tampa Bay Rays and our Tampa Bay Rowdies. So hello from Tampa, or the ongoing COVID surge right now. So a little bit about me. I did my undergraduate from the University of Miami. So I'm a Florida girl, born and raised. I did my master's in public health from the London School of Hygiene and Tropical Medicine. I did this actually in between my third and fourth year of medical school because I always had an interest in public health, in global health. So I decided that I wanted to kind of take that step early in my career. And so I did my MPH in between my third and fourth year of medical school. I completed my medical school from the University of Miami. I went on to do my internship at UMD&J in Rutgers. It's now, or UMD&J in Newark. It's now known as Rutgers. And I completed my residency in Med Peds, which is a combined internal medicine and pediatrics from the University of South Florida in Tampa, where I currently work as an assistant director of the USF Maine Hospitalist Group. So we interact with residents, with medical students, but mostly we do just clinical, we see patients. Right now, our main role has been on the COVID-19 treatment team. So I've been seeing COVID-19 patients for the last 18 months. And I do also, on the side as a volunteer position, I'm chairperson of the Volunteers and Networks Committee of Med Global. Med Global is an NGO that serves in different medical humanitarian trips around the world. And I've traveled with them to many trips, which I will briefly tell you. I've actually been to 7 different countries to provide medical relief. I started as a medical student. Actually, as an undergrad student, I went for my first non-medical trip and then continued as a medical student. That's where my interest really kind of peaked. And I realized that I wanted to do this as a part of my career. So these pictures are from Guatemala, Haiti. I've been to Jordan to work with the Syrian refugees. This picture right here is from Bangladesh. I've been to the Rohingya refugee camp many times with Med Global and OBOT Helpers, which is an NGO based in Bangladesh. And this is in the north of Pakistan. I went to a clinic there. So I've on my kind of off time, that's my passion and one of my callings. So what's Med Peds? A lot of people hear this term, don't really know what it is. And I'm here to let you know that this career is an option for many people. And it's actually, I love being a Med Peds physician. It's 4 years of residency training. And it's combined internal medicine and pediatrics. So your time is basically split evenly between internal medicine and pediatrics. There's probably a lot more inpatient care because, they have to combine 2 specialties into one. So you're getting a lot more of the harder rotations, a lot of the ICUs, the pediatric ICUs, the PICU, so the neonatal ICU, the NICU, cardiac ICU. So you're getting a lot of those rotations and maybe less of the outpatient stuff. There are currently 78 programs in the US. And at the end of this, you have the ability to become dual board certified in internal medicine and pediatrics. So you take both exams, which can be difficult to do in 1 year. Some people space them out, but you have you're dual board certified and you are completely an internist and completely a pediatrician, which is great. After this, I think you feel really well trained enough to do inpatient or outpatient care because your training is so heavily focused on some of the more difficult things. And our clinics are really strong in Med Peds. We feel really ready to do either option. And more than half of Med Peds physicians have some type of academic appointment. And I think this is really because most of these 78 programs are at academic institutions. So our objectives today are to describe the global COVID-19 crisis, give a brief overview of symptoms and timeline, define the severity categories that determine treatment, discuss current treatment options, briefly describe critical care management, briefly discuss inequalities of this pandemic, and discuss the Delta variant. So let's take a global view. What's happening with COVID-19 right now? As you can see, 210 million total cases worldwide, over 4 million deaths. And we have lots of vaccines administered, but many more to go, obviously. And as you can see kind of the big hot spots here that are highlighted in red. So what about the United States? So we have a total of 37 million cases, 625,000 deaths, and we've had many vaccines administered. But this number right here, even though it looks really big, really only accounts to about 50% of the US population. As you know, the Biden administration had wanted it to be 70 or 75% by the end of last year, by the beginning of mid of this year, and that didn't happen. The vaccine was just approved the end of last year. So that we haven't reached that yet. The goal number for herd immunity is really closer to 80 to 90% because obviously there are vaccine breakthroughs. So until we kind of get to that place, we will be seeing a lot of cases and surges like we are right now in Florida. So let's talk about COVID-19 and the timeline of symptoms. So as many of you have heard, even prior to this Delta variant, there was a period, or there can be a period of patients being asymptomatic spreaders, right? Or spreading prior to showing symptoms. So that can be up to 5 days. This is the incubation period. a lot of times patients will start showing symptoms 5 days after exposure. So that's why, you know, a lot of patients will often ask, you know, I was exposed to someone, should I get tested? We usually say, wait a few days, because if you get tested right away, you may not, the test may not be positive. So we usually say, wait, you know, 5 to 7 days. So then the fever, the onset of symptoms, and as you know, a lot of the common symptoms that we have for many viruses, fever, cough, fatigue, anorexia, myalgia, diarrhea. With COVID-19, as you know, there's loss of taste and loss of smell. With this Delta variant, we're seeing more runny nose type symptoms. A lot of patients are describing, so it's a little bit different than the classic cough and fatigue. And patients are still describing a lot of fatigue, but there's maybe more runny nose, headache symptoms with the Delta variant. And then the median days to onset after development of symptoms. So a lot of times we're really seeing this, that shortness of breath, dyspnea, develops in about 40% of patients from days 7 to 10 is what we're seeing in our clinical practice. So patients may be diagnosed, you know, around here, their symptoms may start, you know, in day 6, 7, 8, 10, sometimes they come into the hospital complaining of worse shortness of breath and maybe even needing oxygen at that point. Of these patients, 14% are having severe symptoms and 5% are critical. So what does that mean? And I'll talk about that in a second. So what are some risk factors for having severe COVID? You've probably heard of all of these. These are all over the media. You know, somebody being older, so over the age of 65, somebody with chronic obstructive pulmonary disease, or really any kind of pulmonary disease, asthma in younger kids, anyone with cardiovascular disease, so heart failure, coronary artery disease, any kind of cardiomyopathy, type 2 diabetes, obesity, meaning a BMI of over 30, sickle cell disease, chronic kidney disease, immunocompromised state from solid organ transplantation. And that really means because patients are on immunocompromising or immunosuppressants, so medicines that decrease their immunity. So it's difficult for these patients to mount an immune response. And then cancer, same thing. So there's a lot of talk about what kind of tests should people be using, the PCR test versus the antigen test. And I wanted to just show this slide from Nature, which I thought was really nice. The high sensitivity PCR test. So the PCR test is more sensitive. So, and less sensitive is the rapid antigen test. So this is the one a lot of places right now are doing, the 15-minute rapid test that you're hearing about. That's the antigen test. So that's low sensitivity. So it's for somebody that, you know, is not really sure, but if you have a high suspicion and that test is negative, really, they should get a PCR test. So you can see why it's low sensitivity, that they really don't start turning positive until later on in the time of symptoms. They have to have a lot more antigen to be detected by these tests. PCR test, which detects actual viral parts of the virus, can pick up a little bit quicker. So if somebody's really, you know, goes for a rapid test and they're having symptoms and the rapid test is negative, we usually say you should probably follow up with a PCR test. If they are having symptoms and the rapid test is positive, they have COVID. No need to follow up with a PCR. But, you know, so you can always start with a rapid test and kind of delineate where the patient needs to go after that. So I thought this was a good time to review sensitivity and specificity, especially those of you that are studying for boards. This showed up on my boards on my step 1 or step 2. I think it definitely showed up. But sensitivity, as we know, is just a quick review. So it's true positives over true positives plus false negatives. And specificity here is true negatives over false positives plus true negatives. So if you remember, it's SPIN and SNOUT are the two acronyms many of you have probably heard. So specificity rules something in and sensitivity rules something out. So those are the ways to remember. So if your test is negative and it's a highly sensitive test, it will be ruled out. Whereas if it's specific and it's highly specific and your test is positive, it'll be ruled in. So let's talk a little bit about severity classification of COVID-19. So there are different categories based on what the symptoms a patient is having. So the pre-symptomatic or asymptomatic phase is basically when somebody tests positive, but they are not having any symptoms. Mild illness may be they have symptoms of COVID-19, but no real shortness of breath, dyspnea, or abnormal chest X-ray. So they may be having some fevers, maybe a little bit of cough, some runny nose, fatigue, right? They may be having those symptoms. Moderate illness is when they're showing signs and symptoms of lower respiratory disease or abnormal imaging. And the oxygen saturation is greater than 94% on room air. So this chart uses 94%. A lot of institutions right now are using 92%, but basically, they are having maybe more shortness of breath. The cough is more severe, and their x-rays may show disease, so pneumonia. And a lot of times patients, when you tell them, oh, you have pneumonia, patients will say, oh, I have pneumonia and COVID. And you have to explain, actually, your pneumonia is COVID, right? COVID can cause pneumonia. Pneumonia is just a lower respiratory tract disease. It can be viral, it can be bacterial. So there's a lot of education that needs to happen a lot of times with patients as well. So severe illness is oxygen saturation less than 94% or 92%. Like I said, a lot of institutions are using right now. The FiO2, so this is the PF ratio. So it's the PaO2. So on an arterial blood gas, when you measure that, the PaO2 over the FiO2, which is the concentration of oxygen that's being used, this is called the PF ratio. If it's less than 300 and the respiratory frequency is greater than 30 breaths per minute, normal is less than 20. So between 8 and 20 is usually normal, or lung infiltrates that are greater than 50%. That last one is difficult sometimes to determine based on just an x-ray. A lot of times you will need a CT scan to help make that determination. And critical illness is when you have respiratory failure, so somebody that's not responding to non-invasive oxygen modalities, and I'll go over what some of those are. Septic shock, so somebody that is requiring maybe blood pressure support, their blood pressures are dropping, or multiple organ dysfunction. So in COVID-19, we can see liver failure. Sometimes that's from some of the medications, which I'll go over, but you can also see very often renal failure. So kidney function a lot of times can be compromised from COVID-19, and patients may need to be put on some kind of renal replacement therapy. So how we treat a patient is based on what severity of illness they're having. So when someone is non-severe or they're not having any kind of severe disease, usually they don't need any kind of treatment. Severe, like I said, when oxygen saturation, this chart says 90%. A lot of places are using 92%. So depending on the institution, maybe 92, maybe 90. Respiratory rate greater than 30. Raised respiratory rate in children. So for children, vital signs are age dependent. So a respiratory rate in a newborn of 20 or 30 even can be completely normal, whereas in a 12-year-old, it's not normal. So you have to look at their age to determine what their vital signs are, what is normal for their vital signs. And then signs of severe respiratory distress. So usually that's, a lot of dyspnea, a lot of exertional hypoxia, things like that. And critical illness is that requires life-sustaining treatment. So what are life-sustaining treatments? We'll go into some of them, but maybe intubation and being put on a ventilator, vasopressor support, which are vasopressors are medicines that bring up somebody's blood pressure, dialysis, so renal replacement therapy. A lot of patients sometimes have to be put on that. Acute respiratory distress syndrome, which is something very common that we see in COVID-19 patients. That is based on a classification of oxygenation and FiO2 that I said, the PF ratio. So if your PF ratio drops below a certain number, you're considered to have acute respiratory distress syndrome. Sepsis. So sepsis is kind of like a blanket term, but it basically is when your body's response to some kind of infection in your body. And then septic shock. So septic shock is the response to some kind of infection in your body plus organ failure. So maybe your blood pressure is dropping, maybe your kidneys are failing, things like that. So all of these would put somebody in a critical category. So what are some radiographic findings of severe COVID-19? So this image I actually liked. It's from New England Journal of Medicine's had some really nice review articles over the last 18 months, but this one was severe COVID in December of 2020. And basically panel A shows, here it's very small probably for you, but bilateral ground glass opacities and consolidations. This kind of x-ray, my colleagues and I have gotten good at reading x-rays by now because we're pulling up so many. This is what we would call COVID-y. It looks very COVID-y, like a viral pneumonia. This one, panel B, is a CT of the chest. This also shows the bilateral ground glass opacities, as you can see here, like the gray areas. C is a thoracic ultrasound, which, to be honest, I have rarely used because I'm not a critical care physician, but it shows B lines, which is where the arrow is showing, which is that, the ground glass opacities that we're seeing on the CT scan. And then D is a CT of the head. So this is the brain, and it shows left-sided. So when you read imaging, it's the opposite of what you're seeing, right? You have to think of the patient as being opposite. So this side, left side, where the arrow is, greater than right cerebral infarct. So basically, clots maybe have gone to the brain and caused lack of blood flow, which is what infarct is. So it can cause many strokes. So COVID can also cause strokes. So what are some common laboratory findings that we see in patients with COVID-19? First of all, lymphopenia. So that means when your lymphocytes is low in relation to your white blood cell count. So you can calculate that out usually when you look at a complete blood count or a CBC. It's divided up into neutrophils, lymphocytes, monocytes, different kind of categories of white blood cells that have different functions. So usually, there's a certain ratio that's considered normal in most people. When you see lymphocytes being high, we think of a viral infection. But in COVID, it's interesting, we actually see them being low. You can see elevated levels of D-dimer, which is a marker that we often trend to look for inflammation, and blood clots is what we specifically use this for a lot of times. Lactate dehydrogenase, CRP, C-reactive protein, and ferritin. So CRP and ferritin are both markers of inflammation. So when there's a lot of inflammation going on in the body, these are two markers that we use. We usually check these daily in hospitalized COVID-19 patients to give us an idea of how much inflammation is happening in this patient's body. So we don't look at numbers in isolation, right? When you're talking about patients, you look at patients as a whole. So you have to look at them physically, you have to examine them, you have to see how they're doing, and then you look at their labs as well, and you put pieces of the puzzle together. So that's kind of the art and the science of medicine. So not only do you so looking at a number in isolation is not going to tell me something. I have to see how the patient's doing, if they're getting better, if they're getting worse, and clinically make an assessment by putting all of that together. So these are puzzle pieces that help me figure out how a patient's doing. And a lot of times the procalcitonin level, which is something we use a lot of times in bacterial infections, that this is something that will be elevated in your blood work if you have a bacterial infection. So a lot of times it'll be normal in COVID-19 patients because COVID, as we know, is a virus. So this is evolving science. This was actually a quote from this Yale vaccine researcher, and he's more than a vaccine researcher. I think he's the head of their global medicine department, Saad Omar. But he is, this is an evolving science. You are seeing sausages being made in front of the world's eyes. And I read this quote and I really identified with it because for me, this is the first time in my career, and I've been attending now. I graduated residency in 2015. So I've been attending now for 6 years. This is, the first time in my career that I'm seeing things evolve in a very quick fashion in front of my eyes. We are developing, we have changed treatments over the last 18 months, and that's something that I haven't seen happen so quickly. Yes, things have shifted from when I was in medical school to now. We have, improved technologies, guidelines will change but once we have more evidence to support, certain things, but nothing at the pace that it has now. So we literally are making sausages in front of the world. So I am going to now go into treatment. So transitioning from some of the clinical features of COVID-19 to now, what are some of the treatments that we use? So these are actually the Infectious Disease Society of America COVID-19 treatment guidelines. So they are one of the, chief kind of bodies in the United States that come up with guidelines for treatment of many infections, not just COVID, but they have guidelines for treatments of, community-acquired pneumonias, urinary tract infections, things like that. So they have been updating their guidelines as things have evolved. And as you can see, this is version 4.4.0. So this is just from June 23rd. So the most recent one that they've come up with. And they have a lot of the common treatments that were or considered to be used, as well as what we're currently using. And so I'm going to quickly go over these, and then I'm going to go over what we're currently using. I have arrows by the ones that I'm going to talk about. So the first one is hydroxychloroquine. I just briefly put that in because you probably heard a lot of buzz about this in the media last year, Plaquenil and hydroxychloroquine, and how you can take it to prevent COVID-19. Initially when this started, the pandemic started, we were giving hydroxychloroquine to patients. So last, March through last summer, really, we were giving hydroxychloroquine because we didn't have good data on what worked for this virus. So a lot of what we were doing at the beginning of this is different than what we are doing now. We've gotten better at treating this, but I want to emphasize none of this is a cure. None of what we're doing right now is a cure. There's no cure for the common cold, right? Same for COVID-19. It's a virus. Fortunately, we don't have a cure for it. We're better at treating it now, 18 months in. We know how to manage it, but unfortunately, there's no way to cure this once you have it. So we were giving hydroxychloroquine, or Plaquenil is the other word. There's a lot of buzz in the media. Our former president really touted it, right? So it's now, as you can see, across the board for mild to moderate, severe, non-critical, and critical disease, it's not recommended to be used. It was just shown to not really be beneficial, and actually it was found to have cardiac implications. So, arrhythmias and things like that. It can cause in a lot of patients that would present very ill because they had many comorbidities. So we don't use Plaquenil anymore. And we don't recommend it for prophylaxis either. So people that, get sick with COVID at home and want to take something, don't tell them to take Plaquenil, because most likely they have some kind of a condition that would interfere with this medication, or their other medications may interfere with this. So it's not something to be taken. Steroids are something that we do use regularly now. It's kind of amazing because at the beginning of this, we were not routinely giving steroids, which is, against all of what we know about respiratory illnesses. We use steroids very often in ICU management in patients that present with shock, septic shock, in asthma, like flare-ups, things like that. We often use steroids. So it was really odd initially that we were not doing steroids, because the thought was that it would actually increase viral replication and viral shedding. But thank goodness that we had some trials at the beginning that actually showed that steroids do help in these patients. So we most commonly use dexamethasone or the equivalent if that's not available, and that's daily dosing, and I'll go over that. One of the most recent additions is a new drug, it's not a new drug, but newest addition to the COVID regimen is called tocilizumab. So this is actually used, as you can see, in severe non-critical patients and critical patients. And there are very strict criteria in when this can be used. And I'll talk about that in one of the next slides. Convalescent plasma was something that we previously did quite a bit of, but now it's not very common. As you can see, it's not red that we recommend against, but it's suggested against. So it's not something that we feel very strongly about. This was something that we were doing last year, maybe up until spring of this year as well. Convalescent plasma is basically taking antibodies from someone who has had COVID-19 and giving them to someone else. So it's basically like getting a blood transfusion. You consent a patient for getting a blood product because it is a blood product. And the thought was that if a patient has not made antibodies just yet, that they will get some protection from the antibodies from someone else. So we were doing this for a time, and it didn't really seem to be too, like, the data was mixed. There didn't seem to be a great significant outcome, like positive outcome from it. So that's why it's kind of suggested against use. This one, remdesivir, is something that we very commonly use. And it's kind of interesting that you can see that we use it in severe illness and maybe not critical illness, and I'll explain why. So we don't use it in patients that are asymptomatic. Really, to qualify to use remdesivir, which is an antiviral, and I'll go over that next, you have to be requiring oxygen. The thought is that using it in critically ill patients, maybe they're already beyond the point of being helped by remdesivir. Usually we do give it anyway, but it depends on the timeline, and I'll go over that. And then lastly, all these abs that you see, the bamlanivimab, I call this BAM for short, and all of these abs, they're all monoclonal antibodies. So these are all patients that, these are all patients with mild to moderate disease who are high risk of progression. The goal is to get them monoclonal antibodies, and I'll explain what that is and who is eligible for this. But the goal is to try to give this early in the infection, or to help prevent them from getting sick. And this is one of the newest, probably in the last month or two, things that people are talking about in the media. Those of you that are in Florida, it's something that our governor now is really, has been emphasizing the Regeneron, getting Regeneron early and getting people into infusion centers. The state has actually opened up monoclonal antibody infusion centers. So this is, something that they're really working on now. And lastly, I wanted to go over ivermectin. I'm not going to talk about this much, but I'm just going to briefly mention it because it is something that is coming up in the media now a lot. We've had a lot of patients recently come in asking for ivermectin. And when we kind of tried to figure out why, and we realized there's a lot of media coverage about this medication, there are some trials and some smaller studies in other countries, but in the United States, we don't have any evidence that this is actually a medicine that works any better than what we're doing right now. So right now, there's not any clinical evidence to support using it. So it's not something that we routinely give to inpatients or outpatients. So let's talk about steroids, corticosteroids. So the one that we use for COVID-19 is dexamethasone. So what are steroids? So steroids basically generate a strong suppressive effect on the overall immune system, generally exerting an anti-inflammatory effect by downregulating the production of inflammatory molecules. And they also enhance the clearance of foreign antigens and dead cells from areas of inflammation by stimulating phagocytosis of macrophages, and reportedly can also suppress cellular immunity while stimulating humoral immunity by modulation of the production of cytokines. So basically, steroids have a lot of anti-inflammatory properties. So the steroid of choice that we use is dexamethasone. We use it 6 milligrams daily for 10 days is current dosing. This can be given IV or by mouth, depending on how sick the patient is. If they're on a ventilator, then we probably give it IV. But the dosing is the same. It's equivalent, basically oral or IV. And most recently, especially from Brazil, there are some data to indicate that maybe in the sickest of patients that a higher dosing protocol may be valuable. So these patients, they usually do 20 milligrams daily for 5 days and then 10 milligrams daily for 5 days. So it's a different protocol. And sometimes in some patients that are very ill, the course may be extended. So a lot of these things we don't have a ton of data for. We're going based on some studies. Maybe in a few months we'll have more data to clarify the use of higher dosing regimens in certain populations. But right now, the main kind of treatment is the use of dexamethasone. So what is remdesivir? So remdesivir basically had an emergency use authorization, and then now is FDA approved after multiple trials were conducted. So this is an antiviral that works by blocking viral replication. So as you can see, this is just kind of a summary of how it works, this image right here. So remdesivir, when it comes into the cell, basically just helps prematurely terminate RNA replication of the virus. So, when it does that, hopefully, if it can decrease the amount of viral particles that are actively causing damage, it can, hopefully, over time, patients will have a lesser of a viral load and start to improve. So usually the studies have shown that for this to be effective, it has to be given within 7 to 10 days of symptom onset. So why is that? Studies are showing that in 7 to 10 days is kind of the peak time for when virus is replicating, as I showed in our first slide. Somebody can actually have the virus for up to 5 days before they start showing symptoms. So if you're at 7 to 10 days, you're actually at day 12 or to 15 of the virus being in your body. So the thought is that peak time of the virus replicating in your body has already passed. And once you're past that phase of that peak time of the virus replicating, really what you're left with is the inflammation that COVID-19 leaves behind. And that actually can be more damaging than COVID itself. So a lot of times, when we're talking to patients about course of illness, we have to explain that we're probably through this window, and now we're dealing with the inflammation left behind, the damage that COVID has left behind because of all of the inflammation that it causes. And I'll talk a little bit about the inflammation when I get to the tocilizumab slide. But that's why, there's a small window where we think that remdesivir is more effective. Usually it's given over 5 days. The first day is a higher dose. It's called a loading dose. And then it's 5 days. It's an IV medicine. It cannot be given by mouth. Some places can extend up to 10, but really the benefit doesn't seem to be too much more than actually just doing 5 days. So most places are doing 5 days to conserve supply. At one point there was a shortage of it, so we were trying to make sure that we could equally provide for our patients. So I know my institution has never done the 10 days. We've always done the 5 days based on the data that we have of the efficacy of 5 days versus 10 days. So this is what I want to explain. So an excessive inflammatory response to COVID-19 represents the main cause of disease severity and death in these patients. So as you can see, this is a very simplified slide, but basically when COVID-19 enters our cells, and these are lung cells, these are alveoli, but when it enters our cells in the body, it basically causes inflammatory signals that causes the upregulation. So it causes our body to really upregulate all of our immune system. So all of the inflammatory response. So it really causes this hyperstimulation of our body's immune system that is called a cytokine storm. So that inflammation that's happening in our body is actually what's causing most of the problem. So it's not the virus itself that's causing the issues, it's this hyperinflammation. So, I think a lot of times people don't really understand how COVID works. And that's one reason that COVID has been very difficult to treat, because it's not necessarily that you're treating the virus itself. You have to treat your own body's hyperinflammation, your body's response to the virus. So, this cytokine storm is what we call it, can lead to ARDS, which is that acute respiratory distress syndrome, because of all of the inflammation that it causes in the lungs, which can lead to lung fibrosis, which means that the oxygen cannot pass well between the lungs and the blood. Multi-organ failure. So as I'd mentioned, it can cause inflammation in other places like your lungs, like your lungs, your kidneys, your liver. So kidneys, a lot of times patients will need to be on, dialysis or other renal replacements for short times, or maybe even long-term, depending on what kind of damage is left behind. This hyperinflammation syndrome, which is just lots of inflammation everywhere. So a lot of times patients will have fevers, their inflammatory markers, so all of those labs that I talked about earlier, their CRP, their D-dimer, their ferritin, these are markers of inflammation, will be very high. Sometimes patients will have fevers up to 102, 102 Fahrenheit, 103 Fahrenheit, which is, really high for an adult patient. We see fevers like that in children, but in adult patients, it's not very common. There are not that many organisms that cause, that kind of a fever. You have to be pretty sick usually. So usually you're septic. So hyperinflammation is, these signs are part of that syndrome. And all of this, when the body is so inflammatory and your multiple organs shut down, eventually can lead to death. So what is tocilizumab? So tocilizumab is, like I said, kind of the newest addition to our treatment regimen or our treatment options for COVID-19 patients. So it's not used in every COVID-19 patient. You have to use it in a very specific population of patients for this to work, because it's a really strong medicine. It's an IL-6 inhibitor. IL-6 is actually one of the parts of the inflammatory cascade. And as you can see here, this is actually kind of a brief, a simple way to explain it. So IL-6 is a signal pathway into the cell. So, and then this causes all of this inflammation to happen. So IL-6 can, increase all of this in these inflammatory cells. So it can increase cytokines, it can increase a lot of leukocyte migration from the blood vessel. It can increase foam cell formation, a lot of this stuff. So just basically, it can worsen some of that inflammation. So that cytokine storm that I talked about, one of the things that drives it is IL-6. So the thought is that if we shut off the IL-6, maybe they won't have as much inflammation, that some of this inflammation will be turned off. So if we can block it before it can, attach to the cell, IL-6 is something that our body makes. It's one of the parts of the inflammatory cascade. So if we can block it from binding, maybe we can stop some of this from happening. So the criteria for use of this very strong medicine. So if you think about it, because we're blocking a part of our immune system, it's basically like shutting off part of our immune system. So you can only use it in very specific populations. So the patient has to be recently hospitalized. Usually it's within the first 3 days of admission. They have to be getting worse, like their oxygenation is getting worse. They're requiring more oxygen. And they'll have increased markers of inflammation. Sorry for the misspelling, but increased markers of inflammation. So the CRP is usually above 75 milligrams per liter. So that, like I said, is one of the markers of inflammation that we trend over time. And they should have no other systemic infection. Why is that? So if we're turning off part of your immune system, we're turning off your ability to really fight any other kind of infection. So if you have another type of infection, a bacterial infection, a urinary tract infection, if you're on antibiotics for anything, if we turn down part of your immune system, that infection can get worse, right? So because part of your immune system's gone, and you may be able to treat some of it with antibiotics, yes, but part of recovery of any illness is your body being able to fight off what's happening. So you can't have any other kind of systemic infection. And usually we choose patients that are not immunocompromised because their immunity is already so low. So if, like a transplant patient, for example, that's on medicines that cause their immunity to already be low, this is taking away another kind of area of protection for them. So it's not something that's used. So it's actually really interesting because I have used this, and this is not a medicine that we prescribe alone. It's usually given under the direction of our infectious disease experts. For example, if I, as a hospitalist that is managing COVID-19 patients, I round daily with the infectious disease team, with the critical care team, and we talk about every patient every day. The pharmacists are usually there. If I have a patient that I'm concerned about or think that could be a tocilizumab candidate, we'll discuss it. And they say, I think this could be a TOSI candidate. And we kind of go over everything. And then the infectious disease doctors are the ones that make the final decision, because this is their field. They're the experts. So this is not a decision we make lightly, because you are prone to infection for up to 4 to 6 weeks, I think, after this. So anytime somebody, after tocilizumab has a fever, we have to get very aggressive about making sure that they're not having another kind of infection on top of the COVID. So it's not a decision we take lightly, but I have seen personally, some good outcomes with TOSI, that sometimes in certain populations, I think if we target it early enough and the patient is relatively young and healthy, perhaps, or even older patients that are relatively healthy, it can turn off that inflammation and patients start to improve. So I have personally seen some. It'll be interesting to see what the data shows. Since we just started using this relatively recently, I'll be interested to see what comes out in the next few months. So the new kind of thing in COVID is monoclonal antibodies. So what are antibodies? Antibodies are naturally made in our bodies, so to fight off infection. So monoclonal antibodies are antibodies developed in a lab to help our bodies fight infection. So there's a lot of them that are being used that have been used for a long time for other illnesses, and now they're starting to be used for COVID-19. And this is under an emergency use authorization of the FDA. So who is eligible for these monoclonal antibodies? These are patients that are high risk for developing severe COVID and have a positive COVID test and have not been yet admitted to the hospital, and are 12 years of age or older, or at least 88 pounds. So anyone over the age of 12 that has COVID, it's really to try to prevent them from getting sick and needing the hospital. If you're already on oxygen, then it's too late for you to get this infusion. And this is like the Regeneron, the bamlanivimab, the BAM therapy that I was talking about. Now the FDA has approved the emergency use authorization for preventive monoclonal antibodies. So these are people that have been exposed or are high risk for progression to severe COVID-19 and who are either not fully vaccinated or vaccinated but immunocompromised and have been directly exposed, or are at high risk for exposure due to occurrence of an infection within the same setting, such as a nursing home. So these can actually be, so if there's someone, for example, an elderly person who lives with their family, and one of the family members had COVID, the patient tests negative, you can still give this patient monoclonal antibody to try to prevent them from getting sick. So this is something that it just recently passed, and I know at my institution we've just started doing for the last couple of weeks. So what are high-risk conditions that will qualify you for this? So elderly age, being overweight, pregnancy, chronic kidney disease, diabetes, anyone that's immunosuppressed or on immunosuppressant treatment, anyone with heart disease, lung disease, sickle cell, any kind of neurodevelopmental disorders, or someone that's related on a medical related technology dependence. So these are people that maybe dialysis, even though they qualify under CKD, but somebody that has, maybe a pacemaker, or an LVAD, which is the left ventricular assisted device, things like that. So how can you give oxygen to a patient? So there's a lot of different ways, and this kind of shows the progression of how oxygen is given. But basically, there are a lot of options before you get to intubation. So I think we've learned over the last 18 months that patients, once they get intubated, really a lot of times have poorer outcomes. So the goal is to try to prevent them to get intubated. So how do you do that? By treating early, right? By starting all of these treatments as soon as you can, the remdesivir, the steroids, hopefully getting them the monoclonal antibody. But once they are on oxygen, it's just starting the treatment. Sometimes patients present too late. So if they come after 10 days or 12 days, or their antibodies are already positive, that kind of tells us that this has been happening for a while. The only treatment options we have available at that time, because they're past that COVID stage that I talked about, that viral replication stage, and they're in the inflammatory stage, is dexamethasone, is the steroids, and maybe some breathing treatments if they have lung problems and things like that. So there are a lot of ways to give oxygen, and hopefully by using some of these, we can keep patients off of ventilators. That's primarily the goal. Obviously, sometimes you get to a point that we need it, and I'll talk about that next. But there's a normal small nasal cannula. This is the one that just goes into the nose, and it's very small. This can deliver a certain amount of oxygen. There's a there's a non-rebreather mask, which is over the mouth. A lot of doctors don't love this because you can't really tell how much oxygen a patient is getting through this. So it's kind of difficult to quantify. So we don't often use this. Sometimes we'll use this in rescue, if somebody's acutely getting worse, or, in the ambulance, things like that. There's a Venturi mask. This is also similar. We don't always love this because you can't always quantify it. It's hard to kind of titrate these up and down, which you can do with some of these other ones. So we can tell if a patient's getting better, but this is a lot of times used in maybe rescue scenarios. The two that we use very frequently, that I, over the last 18 months, have become very comfortable with managing on my own without the critical care team, because there's so many patients that are sick right now. So we try to use our critical care team for really the sickest of the sick, is heated high flow nasal cannula and non-invasive pressure support, which is like a CPAP or a BiPAP. So this is intermittent pressure or continuous pressure. So heated high flow is just, it's the nasal cannula as well, but it's very strong. So if you stand next to a patient with it, it's actually very loud. And a lot of times patients don't always like it because it's really strong and it's a lot of flow, and you can give a lot of oxygen through this. The good thing about this, though, is because of that pressure, it opens up the airways, and it opens up those alveoli, which are the lung cells, and that pressure opens it up. So it does work very well. This one, you can go up to 100% concentration of oxygen, which is a lot. So we can actually use these in a lot of patients, and this is one of the main kind of modalities we use nowadays to try to, in the ICUs, to try to keep patients from going on a ventilator. CPAP and BiPAP is the same, but it's a mask over your mouth. And what it does is it actually physically pushes pressure in and out of the patient's mouth. So these patients have to be awake. They have to be able to follow commands, because you don't want to give that to an unconscious patient, because if they vomit or can't respond to you, it can be even more dangerous and can cause, worsening lung function and things like that. So, it gives a lot of pressure, and it's physically, like, you can see the mask sometimes moving up and down. Patients don't like this one either, but usually when a patient's on both of these, I tell the patient, this is our last step before we get to putting you on a ventilator. So we want to try to keep you off the ventilator. Then the last step, obviously, is intubation. So sometimes these are not enough, even when you're on 100% oxygen and you need to deliver oxygen directly into the airways to get closer to the lungs. And that's what intubation is. So how do you determine who needs to be on a ventilator? So if they have, it looks like their airway is going to be obstructed. So somebody that is maybe have airway closing or an allergic reaction, or they can't protect their airway. So somebody, this last one, encephalopathy or inadequate airway protection, if they're getting very confused and you're not sure if they're going to breathe properly, if they're not responding to you clinically, you don't know how they're going to be breathing. These are some patients that you would want to intubate to protect their airway, to make sure that their oxygen status was not contributing to their mental status getting worse. If their work of breathing is really, really hard, like if they're really struggling on any of the modalities I showed you before, if their oxygen numbers are not improving. So refractory hypoxemia. Hypoxemia means low oxygen in the blood. So if their oxygen numbers are not improving on all of what we talked about before, these are patients that probably need to be on a ventilator. And then hypercapnia is increased carbon dioxide in your blood, and acidemia is a response to having more carbon dioxide in your blood. So this is something that it shows that the patient is not breathing well. As you know, we breathe in oxygen, we breathe out carbon dioxide. So the patient is not ventilating well, and their carbon dioxide is staying in their lungs, which is a sign to us that they may stop breathing. The brain actually has a trigger mechanism when your carbon dioxide reaches a certain point to stop breathing. So this actually is a way that we can protect your not only your airway, but ensure that we are getting enough oxygen in and enough carbon dioxide out, so that your body remains in homeostasis. And basically, as I mentioned, in COVID-19, patients do have acute respiratory distress syndrome. So basically, this is a graph from that severe COVID article that was really good. But you use certain tidal volumes, you calculate based on weight, and you set certain pressures on the ventilator to protect the lung. Because the lung's already so damaged, you want to make sure that that your ventilation, the oxygen going in and out, and the pressures that you're giving from the ventilator don't cause more damage. So this is actually what we call prone positioning. So it's been used since the 1970s to treat severe hypoxemia in patients with acute respiratory distress syndrome, or ARDS, because of its effectiveness at improving gas exchange. So compared to supine position, which is on your back, placing patients prone position, so on their stomachs, causes even more tidal volume distribution, in part by reversing the vertical pleural pressure gradient, which becomes more negative in the back, on your back. So the prone position also improves resting lung volumes in the back by reducing the pressure of both the heart and the abdomen. So it's actually interesting. So let me just move this. Sorry, I was trying to see my notes here. Okay, so prone position is actually really interesting, because you saw the patient probably looks funny to seeing a patient on his stomach, but we actually tell patients that are on any of the other oxygens to do this on their own. So if anybody, does get COVID and they're at home and they're getting a little bit short of breath, tell them to lay on their stomach, because it improves how the air is delivered, and you can see why. So in this is supine position. So this is on the back. So you can see the lungs are on the bottom. So imagine this person is lying on the back, and this is the bed, right here on the bottom underneath. This is the spine right here. So imagine this person is lying down here, and the heart is pushing down, right? The heart and everything is pushing the lungs down. It's pushing this way. But when you move the heart out of the way, in this position, when you put them prone position, sorry, this is supine position here. Yes, supine position, prone position, normal lung. So you see the heart goes on the bottom. So when you take somebody from their back and turn them onto their stomach, the heart moves out of the way, and it's basically gravity, right? So all of the lung has so much room, the lung has so much more room to expand. So this is a patient with ARDS, and this is the CT version. So you can see this gray, all of this gray is basically the ground glass opacities or the fibrosis that's been happening in the lungs. And when you position the patient on their stomach, as you can see, this is them supine and this is them prone. You can see the black areas, which is the areas that the air is so much bigger because it's gravity, right? So if you take the heavy stuff out of the way, the gravity is going to work to improve the oxygenation and the aeration of the lungs. So it actually has been used for the last like 50 years, like I said, in ARDS patients. So I actually have this video that I'd like to show. So this is just music, so I don't know if you can hear it, but
start by employing slide sheets in a setting positions. By lifting the patient using the left arm. Applying slide sheets follows safe practices in accordance with patient guidelines. Place the two balls far apart in one. When turning the patient for ventilation, the torch is laid in the direction of the ventilator. Manage the patient's head and neck. Ensure the tubes and invasive organs are correctly used. And anterior ECG electrodes have been used. If pillows are being used to help keep the abdomen free when in prone position, these can be positioned now. Slide sheet by grabbing the corner. Start by applying.
so that's it. I just wanted to show you like what a big process this is. So COVID-19 management in a COVID unit, it takes an entire team. As I'd mentioned, as a physician, I don't manage this alone with the infectious disease doctors, the pulmonary critical care doctors, but it's not just the nurses. As you can see, it's 4 people that need to be there to do this job. You can imagine an entire unit of patients that need to be proned. That's a lot of work. So it takes not just nurses, it takes physical therapists, it takes occupational therapists, it takes respiratory therapists. So a lot of people to manage COVID-19 patients. It's a team effort. And you can see, how somebody needs to stand at the head of the bed of the patient to make sure that the breathing tube that's down the patient's throat doesn't come out, because obviously that will cause problems. So somebody is just at the head to manage that. And then this one was using a lift machine, but we've actually been able to do this with just sheets and sliding sheets under a patient, and then lifting one side of the blanket and being able to turn that way. So it does take practice. It's not something that every unit is always used to doing. At the beginning, I remember our units were not used to doing this and had to come up with protocols and things like that, but became excellent. And, usually we do this for most COVID-19 patients once they reach the point that their lungs are in ARDS. So usually when you do this, patients are prone, so their stomach down for 16 hours, and then you turn them back onto their back for 8 or until they can't tolerate it anymore. The goal is with this process that they will be able to stay on their back longer and longer and longer, so that their lungs continue to improve and the ventilation continues to improve, so that you can stop doing this, but you basically keep doing it until patients improve. So I'm getting close to the end of time, but basically COVID can cause clots. You've probably heard a lot about that. It can cause venous thromboembolism. It can cause myocardial infarction or heart attacks. it can cause pulmonary embolus, DVTs, deep venous thrombosis. So basically, we want to treat that. So COVID-19 patients, we do monitor labs D-dimers every day on patients. If patients are starting to look worse, we start to figure out, do tests. So either a CT scan of the chest to see if they have a clot in their lungs, or maybe ultrasounds of their legs to see if they have clots in their legs. And we treat based on what we find or what we don't. If patients in an ICU, they may need some higher dose prevention than if they were not a COVID patient. So this is something that, has continued to evolve the last 18 months. There is always a risk of bleeding in patients that are on higher prophylaxis or higher prevention treatment. So that's something that we do have to watch out for. And of course, there's the post-acute COVID, or what a lot of people in the media are calling long haul symptoms. So long haul symptoms affects 10% of what, this is as of March, the estimate is about 10% of patients that have been impacted with COVID-19 will remain symptomatic, and a smaller proportion will remain symptomatic for months. And what are some of these long haul symptoms? So patients often describe fatigue, decrease in quality of life, so muscle weakness, continued shortness of breath, cough, and this is from like the fibrosis or the damage that the COVID has left behind the lungs. A lot of people describe cognitive disturbances, a brain fog, like memory gaps patients are describing, PTSD from being so sick, anxiety and depression. A lot of patients are also describing chest palpitations. Some people actually do develop clots and need to be on treatment for that. Some patients go into some kidney issues. So they may not necessarily have kidney failure, but their kidney function may have worsened during this time. And another one is hair loss. A lot of people are describing hair loss after this. So this pandemic has magnified every existing inequality in our society, like systemic racism, gender inequality, and poverty. And this was actually from last year. But this is from anybody that follows the CDC, that MMWR, the Morbidity Mortality Weekly Report. So this is a weekly report that the CDC does put out, and this is from last year. So it was from January to October of last year, they estimated about 300,000 more deaths than typical number of deaths during the same period of previous years. So excess deaths, 2 of 3 out of these were due to COVID. And the largest percent increases were among Hispanics and adults aged 25 to 44. COVID-19 impacted Blacks and Hispanics at much higher rates. Black people are 5 times more likely to be infected with the virus than white people, and Hispanics actually are at a higher proportion as well. So why is this? This is because of why is there higher? So not only is there higher morbidity, but there's also higher mortality in Blacks. So Blacks make up, in the previous slide, it said, so 13% of the population, but estimated 60% of COVID deaths occurred disproportionately in Black counties. So it was much higher death rates than the percentage of population that that Blacks make up. So why is this? So because oftentimes they have increased exposure to COVID-19. So maybe due to residential crowding, to be in a frontline occupation, like if you are in transportation or service or environmental services, you may come at risk. You may be working, in a grocery store or, somewhere where you interact with a lot of people. So you're more likely to catch it. So high burden of comorbidities that are not effectively treated. There's a higher higher burden of hypertension, diabetes in Blacks in the United States. So this is part of the systemic failure that we have in the systemic kind of inequities that exist for minority populations in the US. And that a lot of times creates patient distrust or that itself. And then there's a distrust of the system based on historical mistreatment of this group of people. So people have probably heard of the Tuskegee trials and other kind of trials in American history that Black Americans were used as basically guinea pigs. So there is, patient distrust of the health system. And then lastly, higher burden of unrecognized comorbidity. So this has to do with lack of access to healthcare, lack of patient expectation that engagement would be meaningful. So they would think like, what's the point of going to the doctor? It's not going to be helpful. So all of these things together probably caused higher COVID-related mortality in Blacks in the United States. I did actually an entire grand rounds on just this topic, so I'm going to breeze through these slides. This could be an entire other hour about racial inequities in COVID-19, but basically there's a lot of pre-existing conditions that cause racial disparities in COVID-19. So lack of healthcare, inequities in housing, and inequities in the criminal justice system, inequities in occupations, and then health as well. And then COVID-19 also amplified pre-existing health disparities. So you can see the average life expectancy of Blacks prior to COVID-19 was less than whites and Asians before all of this. So not only is there a disparity in COVID-19 itself, but it's also shining a light on disparities that exist in other health conditions. So what about Delta? So briefly, we are seeing now that Delta is more contagious. It's impacting younger people. It's difficult to say now if it's because younger people are not getting vaccinated at the same rates as older people, but we're seeing a lot of young people right now in our hospitals, and we're seeing that vaccinated patients can have breakthrough infections and that they can transmit, though it's probably less likely for them, or a less amount that they're transmitting if they're vaccinated. So yes, everyone should be concerned about Delta. This masks being off and everyone, not being careful, that was happening a few months ago after people started getting vaccinated. I think, we kind of have to reel that back now and be more conscious again, socially distance, wear our masks, and avoid public spaces, especially right now in Florida while this is happening. So one good thing that's happened from this Delta variant, though, is that vaccinations are on the rise again. So, there was a peak in March, April, as you can see in the United States, on how many people were getting vaccinated, and it dipped down in June, July. But now people again are getting vaccinated because I think people are seeing how sick people are getting with Delta. So this is from the WHO Director General. In words of conclusion, be safe, be smart, and be kind. So in conclusion, prevention is better than the cure with COVID-19 because there is no cure. We've gotten better at COVID-19 management, but morbidity and mortality still persist. And we're still learning about, the long-term morbidities of this virus. We still are learning about, these long haul symptoms that people will have. So prevention is better than cure. If you can avoid getting sick and getting infected at all, but avoid getting sick, that is the best. And the best way to do that is by getting vaccinated. And for that to happen, for us to get to herd immunity, there needs to be wide and equitable distribution of vaccines. So we really need to overcome a lot of this vaccine hesitancy in certain populations around the US. So these are some of the resources I used, and I'll open it up to questions. So this is actually a picture of me in our COVID unit, one of our nurses took. So this is my typical day, wearing my N95 and my goggles and being in full PPE. Right, any questions?
Sorry for that. Thank you, Dr. Ahson. If anyone has any questions, they can feel free to ask now, and we'll now begin our Q&A session. Thank you so much for that very incredibly informative session, Dr. Ahson. And to start off our Q&A, I would like to ask, have you seen COVID cases in the pediatric age group, and usually which age group presents the severest symptoms?
Sure. So yes, actually, being med peds, one of the things that we kind of joke about is that we see patients 0 to 150. So, I have treated many patients with COVID. The youngest patient I took care of was 9 days old. and the oldest patient that I took care of was in their 90s. So I've seen the entire spectrum in this last 18 months. So far, the youngest patients haven't gotten very sick. There have been cases, but usually they tend to do okay. Other than I just admitted just the other night, I'm doing nights at our children's hospital right now, a 20-month-old that was a former preemie, former 24-week premature baby that came in very sick and had to go to the ICU for higher oxygen requirements. Hopefully she will stay off a ventilator, but came in pretty sick. Luckily, mom was on top of things and brought her in, and she was tested quickly and we started treatment quickly. So hopefully, as I showed in the slides, starting the remdesivir and dexamethasone early will hopefully maybe help prevent getting to a worse stage. But what we're seeing now is actually the adolescent population that's really impacted by this, because a lot of these teenagers, 14 through 18, are adult sized. Many of them nowadays, as we know, there's an obesity epidemic, are overweight, and some may have undiagnosed issues. I took care of a 17-year-old that came in 300 pounds with undiagnosed diabetes. So, both of those things put her at higher risk, her obesity plus the fact that she had diabetes. And she was in our ICU for many days. So I think the teenagers is where we're really seeing a lot of illness in the pediatric population, because they are adult size. We are seeing younger patients that are getting sick. We are seeing this MIS-C, which I didn't even get into, and that could be a whole other 1-hour talk, but this multi-inflammatory syndrome of children, MIS-C, we are seeing that in children. So that's perhaps after the acute infection. It's because of that inflammation that I talked about, and it just impacts children differently. So, patients can come in very, very sick, a lot of times with GI issues, so gastrointestinal issues. I personally have taken care of 2 patients that went into heart failure, didn't even know they had COVID, basically, were asymptomatic during that time, or very, very minimally sick, and then come in a few weeks afterwards and are very sick from this. And that treatment's completely different than how you would treat COVID-19, because, like I said, that's after the infection. You're dealing with the inflammation. So that can be in any age group. And we have seen severe illness in different age groups. So, children in general are doing better with COVID-19 than adults for sure, but there still is a chance of them getting sick. And unfortunately, in the younger kids, we don't really know. I think this 20-month-old is probably because she was so young, and maybe she has lung issues from being so premature. But that 9-day-old that I took care of was completely fine. So I think, it's difficult to predict. The adolescents, I think, are acting like adults, like their bodies are acting like adults, in that they do poorly if they have any of those risk factors.
Okay, thank you so much. And on that topic of the pediatric population, given the Delta variant is rising and your focus on public health, what are your thoughts on reopening schools in person in the upcoming fall in Florida and nationally, given elementary and middle school students are not vaccinated yet because it's only approved for individuals over 12?
Sure. So I think, first of all, as a pediatrician, everyone over the age of 12 should get vaccinated ASAP. I think, it was approved a few months ago, and I hope that a lot of people got their kids vaccinated before going to school. But, talking to some parents that, kids have come in sick, and I talked to them about vaccination, and a lot of parents actually don't know that it's approved for 12 and up, which is unfortunate. And, they landed up in the hospital. So first of all, everyone over 12, I think I would definitely recommend. We're not seeing effects. There were some cases of myocarditis, so basically inflammation of the heart, after the administration in a certain population, but that was so few cases over the millions of kids that have been vaccinated now, and compared to the risk of MIS-C, which there can be heart issues, which is a much higher rate. I think as still the American Academy of Pediatrics recommends vaccination. So that's first. Secondly, I think obviously being out of school does have detrimental impact on children's mental health. We've seen a rise in depression, anxiety, and suicidal ideation over the last year in the school age population, especially teenagers, probably from being idle at home and not being able to interact with their friends and things like that. So obviously being in school is priority, but we want people to do it safely, right? So we want people to be safe about it. In Florida, there's this big debate about mask mandates. A lot of school boards now have gone kind of around him and said that, we will have, and you have to opt out of having masks. And actually now even there are some counties that have said, because of the rise in COVID in schools, friends who have children in schools that, are getting of kids being positive and exposures in classes. And, one of my friends, her child has to quarantine right now at home for 10 days while so actually some counties have now said, we don't care what the governor says, we are going to mandates, and it's going to be mandatory for the next 30 days. So anyone that comes to school, so there's actually the Florida education, they are going to withhold funding from those school districts. So it's a very political topic in Florida. I think COVID has been politicized around the country, from masking to vaccination. I think unfortunately it has been politicized, and the public health aspect has not been emphasized. I would recommend that if kids are going to school, kids are vaccinated, that they, if they are over 12, if they're not, then, if there's an option for smaller class sizes, if that's an option, if there's an at-home option, then obviously back to work and kids have to be in school. So then universal masking, masks not only don't really protect you, it protects those around you, right? So like a cloth mask, a surgical mask, if it prevents being spread and somebody else is wearing a mask, it really protects that other person. So when we think about it in that way, with the fabric masks, when he's the only one in the class wearing a mask, doesn't really protect him. So it has to be, I think universal masking has to be in place for the safety of children to be ensured.
Thank you for that answer. And follow up on kids' vaccines, Madhya asks in the chat about your thoughts or any updates from the FDA for vaccinations for kids under 12.
Hearing through the grapevine that hopefully we should be having some information soon. I don't know when exactly yet, but I've been heard within the next few months we should have something, hopefully.
Thank you. And what are your thoughts on the greater incidence of COVID-19 in the adult population rather than the pediatric population?
So I think a lot of it has to do with adults being immunocompromised or having comorbidities that, lead them to be sicker. Kids in general are relatively healthy. They're not overweight. They don't have pre-existing conditions. So I think that's why we're seeing a lot more, morbidity in adults. And then, so I think that's one major reason is because, like I said, the teenagers that are overweight and have diabetes and things like that are getting pretty sick. So I think that's probably one major reason that we're seeing kind of the difference between the adults and peds.
Thank you. And what made COVID-19 more novel than other SARS infections, and how did it strike the world without us noticing, and how come we haven't been able to overcome it relating to the other SARS infections?
I wish I had the answer to that question. I would be winning a Nobel Prize. Unfortunately, I'm not an infectious disease expert, so I don't think I can comment on, the global perspective. I think this virus was just mutated a little bit differently from different ones, and the way that it mutated. And I mean, we can see it even now with the Delta variant, right? That mutation, that little mutation, which happens when it's transmitted from one person to another, that little mutation is enough for it to be more contagious and more and impact younger people differently. So, I think this virus just had the mutations or had something that our immune systems are not used to. I think the inflammatory aspect that we're seeing, that really ramp up of the inflammation, is something we haven't encountered a lot, and initially probably weren't treating very well. So now that we're using steroids and then the tocilizumab, we're trying to kind of attack that part of the virus. But I think, and it just was very contagious. If you look at the R naughts from the public health perspective, the R naught of this virus was so much like, it was much more contagious than the way that it was mutated. It was so much more contagious than any other viruses, than the flu, than chickenpox, than anything like that. So I think all of those factors together just really caused this to happen.
Thank you. And how do you differentiate viral pneumonia from COVID-19 radiographs?
It's difficult. So what really helps is the PCR, right? So a lot of times viruses can also cause ground glass opacities and things that you can see. It's very similar. So a lot of times this is not specific to COVID-19. So the PCR will help differentiate whether or not it's something else. So a lot of times in patients like this, if the PCR is negative for a patient and we're still suspicious, we repeat it. If they're acting like COVID, we repeat the PCR. We've actually even had patients that were so highly suspicious that we've asked the pulmonologist to do bronchoscopies to get samples, down in the lungs. So bronchoscopy is basically going down into the bronchi of the lungs and getting a sample directly from there. So we've even had to do that in patients we're very suspicious of. And then you can also check like a respiratory viral panel, which can look for other viruses that are very common that may cause something like this. But I think, the severity of the ground glass opacities that we're seeing is probably a lot more, and so the radiologists actually, it's interesting because they kind of put the clinical picture together. So a lot of times when they're commenting on these CTs, they say in the correct clinical context could be COVID-19 pneumonia, so you have to kind of put all the pieces of the puzzle together. Is the patient hypoxic? Do they have an elevated inflammatory markers? And then what does their CT or X-ray look like? So it may not be the X-ray or the CT that's specifically, COVID-19, but it's all of those pieces of the puzzle together.
Thank you. And is COVID-19 lung damage reversible?
So it depends on how much is done. Some of it, if it's a very mild fibrosis, could potentially, if there's a mild fibrosis, it could potentially be improved by treatments like we do for COPD, like we do for asthma, by pulmonary rehab. You may be able to regain some function. Sometimes though, the damage is too far gone that patients may always have some kind of a deficiency left, like for the rest of their life. And actually, we've actually had some patients, many patients now, that have needed lung transplants because of the severity of damage that's been left behind. So it depends on at what stage you are in the damage.
Got it. And I'm not sure if you mentioned this already, but can you tell us more about how COVID-19 can cause mini strokes?
Sure. So COVID-19 can cause mini strokes because of I briefly kind of breezed through it at the end, but it can cause you to be more prone to having clots because it can damage the endothelium of your arteries and blood vessels. So that can cause, that material can basically form clots, and those clots that you can get in your lungs and in your legs, and then laying in bed also too, and you're not moving, your basically cells can form into clots. Those clots can cause damage in many places. So they can go into your lungs, like I said, pulmonary embolus. They can cause heart attacks, myocardial infarction, and then those clots, like small clots, can actually go to your brain and cause a lack of blood flow. So that's what it's called, ischemia, cerebral ischemia. So anything basically related to clots. That's why, you know, we are try to be very vigilant about making sure our patients are on blood thinners, so prophylaxis that helps prevent a lot of these clots from getting too burdensome.
Got it. And related to that topic, have you seen any patients presenting CAD after COVID-19 vaccination, as we know that myocarditis and PE have been reported in the pediatric population?
So I have not personally seen CAD. I don't follow patients outpatient. So, you know, I'm a hospitalist. So I only see patients in the hospital. I personally have not seen any CAD. Myocarditis, like I said, is a very, very small subset of people that patients that have been vaccinated. So I have not seen that either from patients, you know, that have gotten the vaccine. So I don't know that that's a common after effect of the vaccine.
Okay. And is there any role of ECMO in severe COVID-19 patients?
Absolutely. And I actually did not include that. I thought about including ECMO. So I personally have had many patients that have gone on ECMO. So ECMO is basically, I kind of describe it to my families that we speak to on the phone every day for patients that are on ventilators. So when you get to a point that proning, like we talked about proning, when you get to a point that that's not working anymore, and basically you're seeing really, really severe lung damage, maybe patients have come too late in their course, or they've been in the hospital for a very long time and haven't been getting better, or their virus, their disease is just so severe that it's really damaged the lungs. So ECMO is actually kind of a lung bypass. So it's a machine that circulates the blood. So you basically need a cardiothoracic surgeon to do surgeries to put cannulas into veins on both of your legs, and it takes the blood in, it goes into the machine and oxygenates the blood, and it puts it back into the body. So for patients that have really severe lung damage, absolutely, ECMO is an option. ECMO is not a fix. Obviously, ECMO is either temporary in that we see if the patient's lungs start to recover, or if we can get them off the ventilator, on ECMO, off the ventilator, awake and walking to a point that they can go for transplant. So it's for the sickest of the sick patients, but yes, there is a role for it, and we do use it in those patients.
Okay, and as you discussed monoclonal antibodies in one of your slides, what is the projected efficacy of the monoclonal antibody treatment, and could it be mass used as a means of preventative medicine for COVID-19?
So potentially, but I think so. I don't know the statistics on it. I'm sorry, I did not have time to look that up on how much. But I know the data is there to support its use. I just don't know what percentage effective it is. But I think it could potentially be used mass effect. But I think there's some things that limit that from happening. I think that it has to be given IV. So, you know, so that limits who can get it, how often you can get it. The other thing is, like, unless we actually have a reason, I mean, all of us are at risk of COVID-19 anytime that we're out in public, right? So then you'd have to come up with kind of a protocol and who you would give it to when. So that's why I think the CDC has come up with these kind of guidelines, because I think that it would be a very slippery slope if we just kind of started giving it out to everybody. I think we need to have more of a regimented way to make that happen. And maybe it will happen. Maybe if it's something that potentially is, you know, we have enough supply to give it out, you know, to everybody. But I think the rate limiting factor is how it's going to be administered. And right now, I know a lot of in many cities, we're hearing about, infusion centers being really booked up. And like I said, Florida has actually opened up direct infusion centers. The government has opened up some infusion centers to make this happen. So I think how you would get it out is the rate limiting factor.
Thank you. As you were discussing rounding with your team of physicians, such as infectious disease and pharmacy, it sounds like medicine is a team effort with several specialists on the team. Can you tell us more about the importance of teamwork in medicine?
Absolutely. I think, when you go into medicine, none of us can know everything. And that's one thing that, I learned very early on in my career, especially as a resident. You will never know everything. And I think to think that we know everything is dangerous and probably does not serve our patients the best that we can. So that's why I think, as a med peds physician, I chose med peds because I wanted to know a little bit about everything. So I wanted to know a little bit about everything, but I knew that I would not be an expert in anything. So I knew that when I chose the field that, now kind of I've become a mini expert in COVID-19, but I'm still not an infectious disease doctor. I don't know all the statistics. I don't know all of this because I'm not infectious disease. So I haven't been trained in that. But, I think that when you choose your specialty and choose what field you want to go into, you choose based on the interest you have in that field and, the lifestyle, of course, and, the patients you'll be seeing and, whether you want to do inpatient versus outpatient medicine, whether or not you want to be a surgeon versus not. So, I don't do surgery. That's something that, I can know a lot of things and I can treat a lot of basic things. I may not need an infectious disease consult on my patient with pneumonia, like a common pneumonia or a common urinary tract infection. I may not need a cardiologist for every patient that comes in with chest pain if I can kind of evaluate the patient and do the testing that the patient needs to be seen and to ensure that there's nothing acutely happening. So I may be able to treat some of these things on my own, but when a patient needs a stent in their heart, I need a cardiologist. So we need to work together so that I don't burden them with all of the patients that don't need to be seen by a cardiologist. But in a case that does need to be seen, the cardiologist will obviously come and consult and see the patients. Same with our infectious disease specialists. I can manage a lot of things on my own, but I may have a case that it's difficult to manage, or I'm not sure how long a patient needs to be on antibiotics, or what kind of antibiotics will be best suited for certain infections. So I'll have our infectious disease consult. Our colleagues come and see the patient. So there's definitely, I think, as a physician, we need to know our limitations and our knowledge. And you will never know everything. I think that's something really important to take forward in your career. We are always learning. And as we see with COVID-19 in the last 18 months, things have changed so much. We're still learning about this. Like I said, the monoclonal antibody, the tocilizumab, these are all kind of new things that have happened in the last couple of months. So I think being able to have good relationships with your colleagues in different specialties, and then even not your colleagues, right? Like physical therapy, pharmacy, other kind of allied health professionals that work with you. Some patients, some doctors may work with nurse practitioners or physician associates, as they're called now, not assistants, but physician associates. You may work with, people that are physician extenders, so their training is a little bit different, and you may be working as colleagues or more of a supervisory role. So I think, there are so many people that you will interact with. I think it's just important to always be respectful of all of our colleagues, because everybody has something to add. I can't tell you how many times pharmacy has called me and said, did you want this dose instead of this dose, or the home medicine is this, and, this is what was ordered. And, like small things that, because we're seeing so many patients, we may miss as a physician, that the pharmacist has picked up. And I'm always so grateful to get those phone calls. So, there's so many things that we can assist each other with. It's just, I think, good to know that teamwork, in a good environment, if you're respectful of each other and value each other's input, can be very useful.
Thank you. And as you mentioned in your response that you wanted to learn a little bit about everything. So can you tell us the difference between family medicine and med peds, and why you chose to pursue med peds instead of family medicine?
Sure, absolutely. So I chose Med Peds because I did want to learn a little bit about everything, but I felt that learning about three specialties for me was a little much because family medicine, not only do you do internal medicine and pediatrics, but you also learn OBGYN. And it's a 3-year residency program. So you're doing a lot of different rotations in 3 years, whereas Med Peds is a 4-year residency training and you're only focused on 2. So I felt that even though I did want to learn a little bit about everything, I did want to feel competent in those 2 fields. And I didn't, I personally, I loved OBGYN, but I didn't see myself kind of living the lifestyle of, delivering babies in the middle of the night and things like that, even though I do work a lot of night shifts now. But, I think that's one thing that I think it was mainly for me that I wanted a little bit more breadth. I wanted a little bit more exposure to feel confident in my abilities moving forward. The other thing that I chose Med Peds for is, like I said, at the end of training, you can be an inpatient or an outpatient specialist. So you can, we can do clinic. And the cool thing about clinic is you can see the kids and the parents together. You can see everyone in the same room, kind of like a family medicine doctor. But we're also comfortable doing inpatient. So like I told you, I am an inpatient hospitalist. I see pediatric and adult patients, and I feel very comfortable seeing both. In talking to some of my colleagues that are family medicine trained, many of them expressed that they would feel comfortable being an adult hospitalist, so an internal medicine hospitalist, but maybe not a pediatric hospitalist because they don't have that much inpatient pediatric training, but they're very heavy on outpatient training. So I felt that for what I was looking for, I wanted more inpatient training. So those are the main reasons that I chose Med Peds. The other thing about Med Peds that I think if you interact with some Med Peds physicians, you'll know if you're the Med Peds personality. I think Med Peds personalities have a very specific personality type. And when I first found out about Med Peds and started interacting with Med Peds residents in my medical school and then during residency, I just knew that I fit in, that I was that personality type. You have to be, I think, a little bit particular about how things get done and be detail oriented for the medicine part, but then you do have kind of the touchy-feely pediatric side as well. So I think having both of those together, I think that personality, like I've met Med Peds physicians now across the country, and I think we all kind of fit that personality type.
Thank you very much. How do you stay up to date on the latest COVID-19 news and research into treatments? And how do you stay up to date on new research for novel treatments of COVID-19 or other cases you regularly see?
Sure, that's a great question. So I think I'm really lucky in that I work at an academic institution. For those of you that missed the beginning, I am an assistant professor at the University of South Florida, and my faculty appointment and my clinical appointment is through them. So we have grand rounds, we have meetings every week to update on COVID-19. We have weekly team meetings since the pandemic started. We've been having weekly meetings with brief updates, with updates to clinical guidelines. We'll have emails sent out by our infectious disease colleagues about the latest kind of information. They'll stop by on our rounds to kind of discuss what's been happening. And even if I'm not there that day, like if I'm on a different unit or something that day, that information will get trickled down to us. So I think one way for me that I've been very lucky is because I am in an academic institution and it's always there and it's always available. For other things, obviously we have our subspecialists that are around that we can talk to, about kind of clinical guidelines and updates. I think a lot of us and a lot of our colleagues do read some of the journals, New England Journal is one, obviously. But I think for quick reference, many of us do use UpToDate. So UpToDate's actually evidence-based. It's, supported by, articles are cited there, it's very quick and easy. And so most of us use UpToDate a lot.
Thank you. And can you tell us more about your role and day-to-day work as an assistant professor and your clinical, administrative, and teaching balance as you practice medicine?
Sure. As an assistant professor, I think for our internal medicine, so my primary appointment is through internal medicine, but I am at Peds, so my secondary appointment is through Pediatrics. We kind of have two routes. One is that you're an academic hospitalist. So these are physicians that round only with resident teams. So any of you that are looking to do residency or have shadowed or done observerships in hospitals, these are, teams with, residents and interns and maybe medical students that round as a group and talk about patients as a group. So there's that teaching attending, and then there's kind of the non-clinic, non-teaching attending, which is what I am. So I do teach, but more on a one-on-one basis. So I'll have either medical students or residents or PA students follow me maybe for a week at a time at night. A lot of times we interact directly with the resident to give them guidance on patient management because we're the only attendings in-house at that time, other than the critical care teams who are dealing with obviously critically ill patients. So for the non-critically ill patients, if they need guidance, then we are the ones that they reach out to. And then I personally do lecture. I mentioned at the beginning that I do a lot of global medicine work, global health work. So I actually teach courses on refugee health and humanitarian medicine. So I teach for our medical students. They have like a global health track. So I'm a lecturer for that and a mentor for that. I do some research. So that's kind of in my non-clinical time. My schedule is really, I'm 7 on, 7 off. So I'm on for 7 days at a time. That can be a very busy week. Night shift is always 12 hours minimum, probably more than 12 hours. And then day shift can be, 10 to 12 hours. And then you're responsible for all of your patients for 12 hours. During COVID, our shifts have gone longer than 12 hours. Many days we're leaving late because our patients are so sick, or we have, families to call, things like that. So we've all been working extra. And then because we're so short staffed, many of us are working on our off week as well. So I think I worked, 5 or 6 extra days this month because we needed help because we had so much of high volume of patients. So prior to COVID, that was a great schedule for me personally to be able to do a lot of my global health stuff. I could extend my time by moving my schedule around with my colleagues so that I did have time to be able to travel and do clinical trips to, like I mentioned, Jordan, Bangladesh, most recently that I had been going to the Rohingya camp. With Med Global, I saw there was a question about Med Global. Med Global is not like Doctors Without Borders. Doctors Without Borders is actually, you need a minimum of a 6-month commitment there. Med Global actually makes global health accessible to most physicians by providing shorter term medical humanitarian relief trips. So usually these trips are 1 to 2 weeks, and you're always partnered with a local organization, because one of the worst things about humanitarian medicine is this drop and go medicine where you just kind of drop into somewhere and provide some medicine and there's no follow-up, there's no somebody that's there behind you to make sure that things continue in a positive way. So that's actually a very dangerous practice. And like I said, I could do a whole lecture on humanitarian medicine, actually teach a course on that. So we could talk about that. But I think that Med Global provides 1 to 2 week opportunities in clinics that are established. So the Rohingya camp, we work in coordination with our local partners there, OBOT helpers. So they actually run a clinic in the Rohingya camp. The last 18 months, we haven't been able to travel. None of my colleagues and I have been able to go, and I was going to the Rohingya camp like twice a year prior to that. It's being run by doctors there on the ground so that there is no gap in treatment. We're continuing to send funding for medicines and things like that, but the manpower that we're able to send right now is limited. So I think Med Global is actually a really great way for physicians to continue to be involved when they have kind of obligations back home and aren't able to devote maybe a 6-month stretch to a country.
Thank you. And taking into account your work studying racial disparities in health, what is something you believe that communities need to be implementing into their health policies and quality of care to reduce these gaps?
That's a really good question. And, This is a question that I actually would love to work on kind of in the next phase of my career. So we'll kind of see kind of what happens next with that. But I think, we need to have policies that are conducive to people, being able to access health. So I think Obamacare was a positive step in that it provided insurance for a gap of patients that was previously uninsured. Studying in London in the UK, the NHS covers everyone. It doesn't matter if you're employed or not, what your education status is, what your income is. You have a safety net of healthcare. And obviously, if you work and you have a job that provides healthcare, then you can have maybe a better healthcare than the NHS. You can go to private systems, but at least there was a baseline level for everyone. In the United States, prior to Obamacare, there was really no system for healthcare for people unless you could pay out of your pocket if it wasn't related to your job. So I think, especially during the pandemic, having insurance tied to employment when so many people lost their jobs during COVID is really nonsensical to me. I think that we need to have a better system. Unfortunately, in the United States, healthcare has become very politicized. Insurance has always been politicized, but to me, it's crazy that, we don't provide basic care to everybody. So I think that would be, one thing. I don't know if we'll ever get there, because I think, there's a lot of very a lot of influences in different spheres that may block that from happening. But I think expanding coverage for people so that people can afford to go and see a doctor, every few months, especially if they have chronic conditions. How many patients show up in our ER? I work at Tampa General Hospital. It's the largest hospital in this area. So we kind of serve as the county hospital. And my group, being university affiliated prior to COVID, now we're very much focused on COVID, but prior to COVID, we were seeing all of the unfunded, all of the undocumented population that would show up at the hospital. And so probably about 20% of our patient population was unfunded or undocumented. And, how many people delayed care because they didn't have access or they didn't know where they could go? How many people would show up I remember one lady came with a huge mass on her breast and a breast cancer that she just let go forever because she couldn't take time off work to see a doctor. She didn't know what doctor to go to. How many patients run out of their insulin and show up in the emergency room needing to go to an ICU? So all of these gaps are really, I think, dangerous and do burden our health system in a different way. So I think if we can focus on prevention by getting patients in with a physician regularly to do regular checks, we can redirect some of where our money is going right now in our health system. So that would be what I would love to work on. I don't know if it will happen. Like I said, I think we have some very powerful entities that it's difficult, but I think that ideally would be a system that is more equitable and hopefully can catch some of these issues earlier.
Thank you. And for our last two questions, how would you describe your work-life balance as a physician and humanitarian, as I know you just came from a night shift?
It's busy. It's very busy. So I actually right now, I don't have children. So, I'm single. I don't have children. So I do have kind of that time that probably would be devoted to kids, to myself, to kind of do a lot of these things. So in that sense, I don't have those kind of responsibilities and obligations and that time commitment. But balancing everything with friends and family and finding time for everything, I think you just have to sometimes learn how to say no. So not always say yes to everything that is available, or, say yes, but, and kind of do something on your own time. I think I've learned that over time. Maybe early on in my career, I was kind of yes to everything and really kind of overburdening myself. And then secondly, you do have to make time for yourself, kind of chart out that time. So whatever's important to you, whether it's family life, whether it's, whether it's vacation time, whether it's your hobby, whatever it is, I think it's important you make time for that, whatever way that is, that you say like, okay, after, from, 6 to 7 p.m. is dinner time, and that's, what I'm going to make happen. You find a job that accommodates that. You find a job that, that you're home by 5:30 so that you can make that happen. So I think you can choose a career that kind of goes around the lifestyle that you want. Residency is busy. So for those of you that are looking at residency, residency is busy. It's going to be difficult, whatever field you decide to go into. And in those few years, you may not have those accommodations. You may not be able to be as flexible. But once you become an attending, really you can kind of choose what you want to do. Do you want a 9 to 5 where you're in clinic every day and you're home for dinner every evening, that you have your weekends off that you can spend with your kids, but you may sacrifice some vacation time because your clinic, requires you to be there certain weeks of the year? Are you okay with doing a 7 on, 7 off, so that you're home every other week, but the days that you're there, you're busy until 7 p.m. and you may, I have some colleagues that have babies that, miss them on the days that they're late. Babies have already gone to sleep, but they think that the balance is there because of their ability to be home. So, I think you can really choose the lifestyle you want. I think this whole concept of medicine being a sacrifice and things like that, it is because of all the struggle that we all have gone through for our education during residency and things like that. But if you are flexible in how much income you are able, if you are not bound by income, then you can, be flexible in what your schedule is. Like maybe you're somebody that works part-time if you have children and, income's not really kind of the main driver. You can be somebody that works part-time that, works 3 days a week at, or somewhere. So I think there is a lot more flexibility nowadays in having career options and career choices that are more balanced. And I think that this concept of self-care is now, physicians are talking about it. They're talking about mental health. They're talking about the importance of counseling and therapy. And, and so these things weren't a thing 20 years ago. We see all these older uncles that went through it back in the day, and the old school surgeons that, never took a day off and are, and that existed. But I think the culture of medicine really has changed. So I think, there can be much more of a work-life balance.
Thank you so much. And for our last question, do you have any advice for students who are interested in pursuing med-peds and any resources they can use to learn more?
Absolutely. So if you're interested in doing med peds, make sure you do electives and the acting internships, like the AIs, or I don't know what they're called now. And I think every school probably calls them something differently, but something different. But make sure you do an AI or electives in both medicine and pediatrics. Get letters from both, because you will need letters from both. And just make sure that you enjoy both, because I think going through residency training and then kind of saying, I don't really want to do one or the other, it's never a waste, because you will always probably use it at some point in time, but you may as well then at that point just save yourself a year and just either do medicine or peds. I think, like I said before, I think med peds does take a certain personality type. Meet some med peds residents, interact, try to see if you can get on a team with them. Or like I know our university has a med peds team that, is run by a med peds attending that has med peds residents. So see if you can get on that team and interact with them and try to see why they chose what they did and how they think and, what drives them to do what they're doing. And that's how I think I got inspired to do it, because like I said, I met med peds residents as a medical student, and I was like, these residents are really on top of it. They know what they're talking about, and they're really nice. And like, I met med peds attendings and I felt the same way. And I just felt like I fit in. And I think you'll know when you meet more people. So, so just make sure that you're really exposed to both, because I think they require different things, different kind of skill sets, and make sure that you like both fields and have the skill sets to do both. So I think So just get as much exposure as you can. Do your active acting internship or in electives in medicine and peds, and interact with people. And then if you need resources, there's the National Med Peds Residents Association. I think it's NMPRA, .org. If you Google Med Peds, it's like the first one that comes up, and it had the logo that I showed at the beginning. But they actually have like a list of residency programs, what the field is, what people go into, things like that. So they're actually a really great resource. So and I think mentorship is so important. And that's one thing that, when I was choosing med peds, as I graduated medical school in 2010. So when I was choosing med peds at that time, I had a lot of people tell me, like, why are you doing this? You're going to have to choose one or the other. And, you're going to have to settle. Ultimately, it's just wasting a year for you. So I had a lot of naysayers. And I also had a lot of naysayers that told me that I couldn't do global health as, a part of my career and make this something that I did. They said, this is just like a hobby or a time pass or, something like that. Like, it's not something that you'll be able to continue to do. And I think I was able to do both, and I've been able to do both. And my career is so much more fulfilling because of that. And so I think that, those are the things that really drove me to want to be a physician. I've had colleagues asked me, if you had to choose one or the other right now, what would you choose? And it was so hard for me to talk about, like, to figure it out, because I love internal medicine and pediatrics for different reasons, and for me, right now I'm on peds, and I just finished a long time on our COVID unit. So being on peds, even though I'm seeing a lot of COVID, it's different, and it's, refreshing for me. It's like a nice break. It's that balance, and I miss it when I don't have it. So I think you'll know if you're that type of person when you experience it.
Thank you so much for answering all of our lengthy questions, Dr. Ahson. Those are all of our questions for today.
Well, thank you all for having me. You guys asked some great questions, so thank you so much. I think that I gave my email, and I'll type it into the chat again. If any of you have any questions, feel free to email me. I'm on Twitter, that I don't use it very much. I'm on Facebook, so you can find me. Feel free to reach out if you have any questions or I can be of any help. Good luck to all of you.
Thank you very much, Dr. Ahson. We really appreciate you taking the time to answer all of our questions and teaching us about COVID-19. And that was very, very helpful for all of us, especially in a time when the Delta variant is increasing. And we really appreciate it. I'd love everyone to please give a warm thank you to Dr. Ahson in the chat box for us. Thank you so much.
Thank you for having me. Stay safe, everyone.
This
is not over. This pandemic is not over. So we're still kind of getting through it. So if you haven't gotten vaccinated, please do get all of your family vaccinated. That's going to be really our only way of protecting yourself right now. So, and if you have any other questions, like I said, feel free to reach out.
Thank you. That is great advice for all of us. Thank you so much.
Thank you.
Thank you, Dr. Ahson. Now we're going to conduct our closing session with our quiz and future session dates. So the link to the quiz for this session is now live. Again, you'll need a 70% or higher to pass and receive certification. The link to the quiz has just been sent in the chat. Don't forget to join our mailing list if you haven't already, as we send session and quiz reminders right to your mailbox. You can join from the link that's sent again in the chat now. So now we're going to go on to our next session dates. These dates will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. I'm looking forward to seeing you all at our next session, which is next Saturday on August 28th at 11 a.m. Eastern Standard Time, so not 10 a.m., 11 a.m., with our physician mentoring us in preventative and regenerative medicine. Thank you so much, everyone, for attending today's session, and we hope to see you in upcoming sessions as well. This concludes this week's shadowing.